Well, it is an honor to be up here to honor the late, great Dr. Cahill, who was a leader in our field and a leader of this organization, but also to have a front row seat to watch my two big brothers, Mike Wang and Dean Chow, duke it out. It's like seeing your big brothers in the backyard punch each other out. So I'll be very excited about this. So here's our case, and this is to look at endoscopic spine, one tool or the new norm. I have no disclosures relevant to this. So this is the case. This is a 36-year-old lady who had 10 weeks of severe left S1 radiculopathy. She's an APP who works in our neuro ICU. She failed PT, all the conservative measures. And she'd actually been off work for 10 weeks due to pain. She was neurointact except she had 4+ gastroc weakness. She had a BMI of 48. And these are MRI and X-rays. You see the large left-sided L5-S1 disc herniation. So this is actually going to be a twofer. I asked Mike and Dean to argue two parts to this. The first is, what would you offer as the first initial index operation, endoscopic or endoscopic is a waste of time? So then the patient undergoes the procedure, whichever Mike and Dean are going to argue. She has significant pain relief. Then 7 days later, she has a recurrence of symptoms. She has the imaging, which shows acute reherniation. She undergoes operation again, complete relief, returns to work. But now it comes back 6 months later with an even larger recurrent disc herniation. So now she's had 3 herniations in a 6-month time period. So this is the second part of it, which is now what surgical reoperation do you offer, endoscopic versus adds value, or endoscopic is a waste of time? I'll bring to the stage, the first debater is going to be Mike Wang.
Great, thank you, Dan. Okay, so I'm on the side of endoscopy, and I'm going to make the argument that this patient should have an endoscopic decompression because it is becoming the new norm. So, look, I go to Becker Spine first. Endoscopy is on the rise. It is getting bigger and bigger and bigger. Of the 5 pre-courses, endoscopy was the only one that was packed. So I had to know more about who I'm debating against. And here's Dean, 5 things to know about Dean, moving to Columbia. And it even says he performs even complex spinal disorder cases with less invasive procedures. So I have to ask myself, Dean, what could be more MIS than working through a 6-millimeter tube? And I didn't understand this at all, right? I didn't understand what is going on here. Why would someone as smart as Dean do this? And we're so similar. Like, Dean's 54, I'm 53. We're both Taiwanese. We're ABCs, which means American-born Chinese. We're both married to Caucasian women. He's on his second job as MI. We're both spine directors of a major institution. He's above average height. I'm above average size, right? So what else could there be where it doesn't make any sense to me? So then I'm like, I got to go deeper into this. Okay, so Alyssa today answered the question for me because Dean and I differ on one important measure, which is that I went to Stanford like Dan Ho, and he went to Cal Berkeley. And if you think about it, they're quite different as an institution. For example, if you were to think about my time at Stanford, you can see me here working in the lab, doing cell culture, busy doing science, and Dean is here at Berkeley protesting for higher taxes and legalizing weed. What is wrong with this picture? Okay, so, well, if you look at it, it makes sense even more because Stanford brought us Cisco, Limiflex, Google, HP, M6 Disc, Nike, Stem Cell Institute, Yahoo, and Accuray, maker CyberKnife. Cal brought us People's Park, which is a homeless encampment, hippie movement, riots after George Floyd, and they actually have a center for psychedelic research. And so now I got it. Now I know why Dean is doing this, right? We've heard this regressive story before. Argument against lateral mass screws. Just wire, just cable, just do all that. How about like the pedicle screw litigation? Nobody needs screws, right? How about like alternative homeopathy for scoliosis? These are the kind of regressive ideas that say we're never going to move forward with our lives, right? And so I'm right and Dean is wrong because it's about the science, okay? So tubes versus tubes. What are the differences between the big tubes and the little tubes? Here you can see a diagram showing the approximate size difference of endoscopic versus tubular disc. And you can work within the 6 millimeters because you have the ability to turn the scope and look in different directions and do all these great things. And remember, we're operating on the spine, not the spine musculature. Ooh, yeah. And all the trauma to the soft tissue envelope is just collateral damage. The more tissue damage, the more blood loss, the higher the infection rate, the longer the length of stay, the cost of surgery, all these things are added. And this is a young Matt Gary over here doing endoscopic surgery. So much fun to watch other people do this. Everybody gets enamored with endoscopy, right? And look, here's an endoscopic users meeting with 1,000 of our brethren Chinese surgeons doing endoscopy, right? Against Dean, right? Like, why wouldn't you go against all those people, right? So here's an example quite similar to Dan's. Here's a 31-year-old engineer came to me in 2013 with a spondy and pars defect. And you can see that he can't even flex forward on that flexion view on the left. 2020, and I saw him recently again, he is still good with his endoscopic decompression. That's all he needed. He didn't want a fusion. I know he's going to need a fusion someday. He knows he's going to need a fusion someday, maybe in 10, 20 more years. And if you look at it, it costs less. This is a great Korean study. It shows that I don't care what endoscopic you use, transforaminal, interlaminar, UB, bilateral portals, it's still cheaper than a standard microdiscectomy, right? And then think about this. On the left, you can see our visionary level sponsor, our biggest sponsor for this meeting, Globus Medical, is market capped at $1.4 billion. Here's a bigger company, Arthrex, $3 billion, and Arthrex has just launched endoscopy, right? So if these guys are making the wrong decisions, I'm a little worried. But more importantly, it's a stepping stone. So this is a way of getting access so you can do bigger and bigger and more important surgeries. You can do T-lift through tubes that get smaller and smaller and smaller. And I just kind of put it up here for you to see. This is the difference between an endoscopic and a tubular T-lift in the size and destruction to the muscles. You can get all that decompression indirectly. You can do all these wonderful things all with the endoscope, going to things like higher level deformity surgeries, and then even surgeries that begin to add lordosis by sectioning the ALL and doing all these wonderful things. The endoscope is a tool that is versatile, that lets you do better surgery all the time. So here's the deal, right? Diffusion and innovation. Some people are going to be at the front. Some people are going to be in the back, Dean. Get to the back of the bus. You're one of the laggards. And I looked it up. I said, there are people, this is not the first time in history, there's something called a Luddite. In the 19th century, English workmen worried about their futures went around destroying machinery, saying, that's no good. We need to use our hands for everything, right? And that's the point here. We want to move forward in terms of technology. So evolution is inevitable, as is obsolescence. Dean, I hope you're not obsolete. Maybe after this lecture, you're going to get on board. Right. So part two, Cahill debates. So endoscopic is a waste of time. I'll tell you why. These are my disclosures. So as you saw, Mike loves the endoscope. But eventually what happens is that he realizes he's operating with one of his hands tied behind his back, and he can't do as good of a job with the endoscope, and eventually he becomes unhappy. Now, you just saw that last slide. Is evolution inevitable, right? We go from ape to man, et cetera, and keep getting better and better. But think about other things that have happened in spine where the evolution actually hurt us. Axial lift, right? This is said it's going to save money. And then after 2 years, it had 8% fusion rate, right? 2-year follow-up, 8% fusion rate with this product. It's not on the market anymore. What about this? X-Stop. Kyphon bought it for $725 million and then subsequently bought by Medtronic. The whole thing basically didn't work. Says it's basically, it was so bad that this paper, in its conclusion, it said, in conclusion, the X-Stop interspinous distraction device showed an extremely high failure rate. They were so bold as to say, we do not recommend the X-Stop. So this product is basically, totally into oblivion. And then think about other things besides spine as we evolve, as we keep getting new technology, right? Wright brothers, propeller plane, another propeller plane, and then the jet plane, commercial jet plane, jumbo jets. And then what was next? The Concorde. And remember what happened to the Concorde? Right. This is what happens. So when you start getting more and more technologically advanced, and as you keep pushing the envelope, sometimes you just crash and you burn, and we don't have the Concorde anymore. So again, there are limits to the evolution. And I would argue that the endoscope is starting to hit its limits, okay? So you have this case that Dan Ho showed you. You do it open, you get a great decompression, you know that patient's going to grade operation. It's effective. You can use both your hands. You can get a complete view of the disc, of the nerve. Sometimes these discs don't just pop out. They're fibrous. They're tough. You got to go in, push. Again, it's the other thing is you can protect that nerve, right? You can actually push it away, you can dissect it, you can move it, you can very safely retract that nerve. And look at this. As the complexity of the case increases, the benefits of minimally invasive begin to be shown. Meaning, if you do a small case open, you do a small case MIS, there's probably no big difference. The other thing is that, Mike will talk about the speed of the endoscope. Again, the published paper from Hofstetter showed that if you do a decompression with the endoscope, it takes you 40 minutes longer just to do the decompression through the endoscope. So again, you are prolonging the time of the surgery. And endoscopic is not all cupcakes and rainbows, right? If you look at this paper that showed all the complications that are associated with the endoscope, these are things that people don't talk about. People say endoscopy is great, it's the best thing. But think about it, all these complications happen. What happens when you are in that scope of a 6-millimeter tube and you get a complication? What are you going to do? How are you going to fix it? How are you going to salvage it? And it went so far. This is a review actually in a journal that has a symposium on minimally invasive spine surgery. And in their the conclusions, they said the learning curve is substantial, right? So if you don't know how to do endoscopic surgery, it's a big deal. It's generally difficult to incorporate into routine practice. The cost of the instrumentation is significant, okay? The radiation exposure, people rarely talk about that. The radiation exposure associated with transforaminal procedures is more than other minimally invasive techniques. And it should be remembered that conventional microdiscectomy may be more favorable in some patients. And again, I think in the case that Dr. Ho showed, this is a great case for a open microdiscectomy. I think that if the patient had a soft foraminal disc out sitting in the nerve root, I think endoscopy is but for a paracentral disc herniation right underneath the facet, I think the open technique is a great option. Finally, let's go to the third herniation. Again, this is a terrible thing. This MRI looks terrible. Obviously, this patient needs an operation. Time for open TLIF, right? So Mike talks about the minimally invasive fusion, but again, if you do an open TLIF, you're looking at the nerve, you're looking at the disc. It's easy. You're familiar with that anatomy. You take out this disc herniation. You can spend time taking out all the disc. You don't have the limitations of a scope, of a tube. You're not limited by this tiny little view. You get an amazing decompression. And then when it's time to do your fusion, you get your curettes out. You do the fundamentals of great carpentry of spine surgery. Take off that cartilaginous end plate, get bloody bone, put a nice inner body in there, nice cage, great fixation, phenomenal decompression, phenomenal fusion. So open surgery for this case is the way to go. Finally, when we talk about this, for minimally invasive, for the endoscopic TLIF, the DRG, right? The DRG is an issue. Mike Wang says this in his lecture. The DRG, transient symptoms and permanent DRG symptoms. Why you got to deal with that, right? Just do the open TLIF. You don't have to deal with these DRG issues. You just do the open surgery, get a great operation for your patient. Your patient's happy, you're happy. There are no DRG issues. So it's safe. You just see this dura, you dissect everything, great implant preparation, and we're comfortable, right? We're very comfortable doing this operation. You know in your hands this patient's going to do well, and there's no learning curve. So in conclusion, open decompression is the way to go. Get it done right. It's safe. You see everything. You can dissect any redo scar tissue, total decompression. And again, endoscopic still has complications, learning curve, radiation, and it's unclear how extensive your decompression is going to be. Thanks very much.
That was great. Can we get the Slido up for the vote? What we learned in the last one, just got to give it more time, and eventually all of Dean's fans will exit and Mike's fans will pick up here. It's only getting worse for you, Mike. Your fellows are logging in right now. That's it. All right. We'll cap it there. Great engagement and participation. It looks like in this debate, Dean Chow won. Endoscopic is a waste of time.